We're going to continue this afternoon. We're going to talk about novel frameworks to confront AMR in various different contexts. And I'm happy to the next up on our list is to introduce a panel discussion led by Dr. Kevin Schwartz. Dr. Schwartz is the division head of infectious disease at St. Joseph's Health Centre in Toronto and co-medical director for antimicrobial stewardship at Unity Health Toronto. He's also an academic infection control and AMS physician at Public Health Ontario and assistant prof at the Daley School of Public Health at the University of Toronto. He's going to introduce a panel discussion to talk about CANBuild-AMR, which is focused on a framework to combat AMR in primary care, and he'll be joined by a number of panelists and introduce them as they take their turns discussing in the panel. So help me welcome Dr. Schwartz to the stage to introduce the rest of the panel.
Thank you so much. I think we can get the whole panel maybe to come up on stage and they can have a seat, and I'll sort of just do a few very brief introductions. So just to start, there's really no significant conflicts of interest for the topic we're going to be discussing today. And so this is our outline. We're going to introduce the panel. I'm going to give an overview just very briefly with a few slides about what CANBuild-AMR is and what we're doing and what we're talking about, sort of set the stage, and then we'll dive into the panel discussion. And hopefully at the end, at least a few minutes for some audience questions if people want to ask. So this is us in both picture and in real format. So just for introductions, so Katie Kjelland there is a pharmacist with the College of Physicians and Surgeons of Alberta. Katie contributes her expertise to initiatives that support safe, evidence-based prescribing and continuous quality improvement across Alberta's healthcare system. Our next panelist is Peter Daley. Peter Daley is an infectious disease physician and clinical researcher. He's an associate professor of medicine at Memorial University. His clinical practice involves clinical trials and observational research in bacterial and viral infections, diagnostics, and antimicrobial resistance. Our next panelist is Alex Singer at the end. Alex is a practicing family physician, clinician teacher, and associate professor in the Department of Family Medicine at the University of Manitoba, where he serves as the Director of Research and Quality Improvement. He is the network director of the Manitoba Primary Care Research Network, where he leads and collaborates on several regional and national practice-based research studies, including a study using targeted practice facilitation to reduce unnecessary antibiotic prescribing. And last but not least, Noah Ivers is a family physician at Women's College Hospital, academic family health team, and also leads a research program in implementation science at Women's College Hospital. He is a full professor in the Department of Family and Community Medicine at the University of Toronto. He holds a Canada Research Chair in the implementation of evidence-based practice. Noah's research focuses on the use of data to drive evidence-based, patient-centered improvements in healthcare. So thank you to the panel for coming to join us today, and I think it's going to be an interesting and lively discussion about this topic, which is near and dear to me about, related to antimicrobial stewardship. So just sort of level setting, again, a couple slides. So first, basic definitions, right? Like what is audit and feedback? And this is what we're going to be talking about, which is really one antimicrobial stewardship intervention, which we feel has a pretty robust evidence base, which I'll show you, and has been implemented and is being implemented across Canada. So audit and feedback is, the definition is to measure performance, that is the audit part. You then compare to peers or some sort of benchmark, and then we provide that feedback, that data back to the prescriber as the feedback to encourage some sort of improvement in practice. And that's the basic definition of what we mean by audit and feedback. And we've done this in Canada a few different times as part of research studies. And so this is an example of what we did in Ontario back in 2022. It was a randomized controlled trial where we mailed feedback letters to family physicians In this trial, we included over 5,000 physicians, where just over 4,000 got a mailed letter that looked something like this at the time, that had their data with a peer comparison. And then there's a few other pages in the letter that had some tools and resources about appropriate antibiotic prescribing and tried to direct them to how they could change the behavior, improve prescribing in some way. And in this trial, there's about 1,000 control physicians who didn't receive any letter. And overall, it was quite effective. We reduced overall antibiotic prescribing by about 5%, reduced unnecessary prescribing specifically that we could measure by about 11%, as well as some other improvements in prescribing. So small improvements, but on a population scale, pretty important. We're also part of an international group that did this systematic review and meta-analysis of all the trials that have looked at audit and feedback in primary care for antibiotics. And there were 56 different trials that we included in this meta-analysis. And we separated in this image by the type of outcomes they looked at. And when we meta-analyze these, combine them together, there's significant improvements in all of these outcome measures of antibiotic prescribing. And we found an 11% reduction in overall antibiotic prescribing, 23% reduction in unnecessary prescribing, 13% in prolonged duration prescribing, and 17% on broad spectrum prescribing, or the selection of antibiotics. So that audit feedback, if designed well and properly, can be used to impact really any or all of these outcomes in antibiotic prescribing. This is another study we did based on our trial that we looked at whether or not this is a cost-effective measure in stewardship. And it's not just about cost, it's really about improving care and slowing antimicrobial resistance. But we showed this is very cost-effective. For every $1 we spent creating this data and mailing it to physicians, we saved the healthcare system about $9. That's mostly in the cost of the drugs, but it also incorporates visits for antibiotic side effects as well as infectious complications. And so myself and Brad Langford had written this editorial that there's a really robust evidence base related to audit and feedback, specifically for antibiotics in primary care, that the time is now to be scaling this up, rolling this out, and implementing this in order to improve our antibiotic prescribing. And that's really what CANBuild is about. So CANBuild is a national collaboration that is funded by CIHR to basically do exactly that. And so the part that we're going to be focusing on as part of CANBuild is really to this capacity building. We're trying to get partners from across the country. And as most people here know, Canada is not one healthcare system. It is 13 separate healthcare systems with different data sources that needs to be done. And this sort of intervention needs to be done at that provincial or territorial level or at a smaller scale. And we've been operating for a year or two now, and it's exciting that we have representation from across the country. We have partners from 10 provinces and 1 territory that are engaged in this work. The green dots are provinces that are actively implementing some sort of antibiotic audit and feedback, likely over the next 12 months. The yellow are partners that don't have a time frame but are likely going to, and the red are still sorting through logistics like access to data and partners to actually do this at the local level. And the black stars represent provinces or people that are here today to talk to. And so very exciting collaboration with national input. This is our website with a partnership with Choosing Wisely Canada. So they host our CANBuild-AMR website and has a section on audit and feedback and more details about the study and the team. So with that, I will end my introduction and dive into the panel discussion with the team. Maybe there's a chair here. I will sit down. Oh, there, that's working now. Okay, thank you. And so I'm gonna go to my first question, and I'm gonna ask Dr. Ivers the first question. So, in my introduction, we've heard Dr. Ivers is a leading expert in this. And so, as a leading expert in the science of audit and feedback, can you share with the audience your perspective on how and why this works to improve antibiotic prescribing?
Okay, thanks, Kevin. Yep, my mic's working too. Hi, everyone. I think we should just start by making clear that some amount of measurement is necessary for management. This is sort of an axiom that most people hold true, and it's the starting point for any kind of quality improvement initiative. But that doesn't answer your question about why it seems to work. I I just want to also clarify that the question holds the assumption that it does work. And I think we see from the systematic review that, the bottom line is that this is an effective way to nudge the curve on antibiotic prescribing. So that gets us to the question, like, why does that work? And I think there are 2-3 mechanisms that are worth thinking about. One is, in general, audit and feedback works in 2 ways. One is the individual recipient of the feedback just tries harder. And the other is the individual recipient of the feedback puts into place some sort of process that makes things a little bit easier to do the right thing. We would love it if always path 2 was taken, so we don't rely on effort, which isn't necessarily sustainable. But even outside of those generic sort of individualistic or process-oriented pathways, I think it works because it, basically the Hawthorne effect, it makes clear to the recipient that this is something worth measuring, therefore it's important, therefore they should prioritize it. Now, if they act on that prioritization by keeping it top of mind and working a little bit harder at prescribing a little bit less, super. But even better is if they take that report and meet with some colleagues or their department manager or whatever with that information, says, hey, what's your show? Mine shows this. How are you doing that? I'm doing this. And they start coming up with better plans and sharing best practices. That's the ideal scenario. And we can enable that with facilitation, facilitating conversations, things like this. But even without that, we see the effects just sending the report, probably because of pathway 1. That's sort of, well, I guess I'll just prioritize this a little higher. And that seems to, in this case at least, be enough.
Yeah, thanks. That was great overview. Thank you. For the next question, I'm going to jump over to and direct it to Katie. Katie, I'm wondering if you talk a bit about the Alberta experience with delivering antibiotic prescribing feedback to family doctors, including the unique perspective, hopefully you can touch on, that the way that they do it in Alberta comes from the provincial regulator, which is unique compared to a lot of other areas. So I was wondering if you could speak to that for the group.
For sure, yeah. Thank you for that question. So as a regulator, we're super focused on physician practice improvement. So we previously already had a prescribing tool in Alberta. It's called the MD Snapshot. So we send it out to our physicians on a quarterly basis, and it shows them their prescribing data relative to peer comparators. So the important thing to note about this is that it's relative to their own practice and their own patient population. So we don't use it at all as a report card. It's not punitive. It's merely for self-reflection. And a few things that our physicians need to note is that it's not complete data. So we don't have indicator data currently, we don't have denominator data, and we also don't have acute care data from our hospital settings. So when they're looking at the data that we do provide them, again, they just have to look at it and recognize, does this reaffirm my prescribing decisions, or can I make improvements in the future?
Thank you. It's great. Okay, next I'm going to jump over to Dr. Daley. So, Dr. Daley, I was hoping to get your experience from Newfoundland on how this has been done in your province, as well as maybe discuss some upcoming plans.
Thanks. We have been many years in developing a peer comparison feedback structure in the province of Newfoundland and Labrador, which doesn't exist currently. It's been a very lengthy process getting it together because we haven't had good surveillance on antimicrobial usage. And we don't have a provincial college that already gives feedback to physicians. So we are breaking new ground in the province in that sense. And we haven't yet done this, but we're very close. I believe, as a provincial stewardship chair, I believe in the benefit of peer comparison as a competition, essentially. Well, if a certain doctor is doing better work than me, maybe I should compare and improve. So I think it does work. Our college was actually opposed initially to this. We pitched it to them and we said we want to show family doctors that they're doing well or not doing well, and they said we want nothing to do with this. So that set us back a little ways. But the idea that we will experience the same benefits as other provinces have experienced makes sense, and we expect to see improvement. Furthermore, we think about this as the first way to develop what Alberta already has, which is a quality improvement system. It shouldn't just be antimicrobial, it should be benzo, it should be opioid, it should be other quality indicators within primary care. it's the kind of sunshine list that nobody wants to kind of look at, but really it is the only real way we can influence physician behavior in the community. A lot of these physicians are not part of our health system. They're not part of the university for sure. They're private practitioners. How do we communicate with them? How do we make them change their behavior? How do we help them change their behavior? It's not easy, but I think this is a good tool. Thank you.
Yeah, thanks for that. It's great. And they showed that graph before that Newfoundland is probably per population the highest antibiotic using area with a lot of variability across the country, and an important measure to try and reduce prescribing.
We have a bad reputation.
Yeah. We're improving. Okay, so I'm going to go over to Dr. Singer. So, Dr. Singer, I know you have done a lot of great work in Manitoba on antibiotic prescribing and antimicrobial stewardship. I was hoping to get your perspective on how you've been able to implement antibiotic audit and feedback in Manitoba.
For sure. So I'm going to kind of split my answer a little bit in sort of what we've done and where we're going, sort of a bit of a history. So my team got to participate in some of the primordial work that I think made it into the meta-analysis. So back in sort of 2016, 2017, we did sort of a baseline study of sort of the antibiotic prescribing patterns in Manitoba using a practice-based research network approach. So I direct a practice-based research network, which is sort of one of its key infrastructures is we can extract primary care EMR data, we can clean it, de-identify it, and then send back reports to providers, among other things that we do with the data. Most of that infrastructure was actually set up to be able to do chronic disease surveillance and reporting, but of course, once you have prescriptions and diagnoses and other things like that, you can do other interesting things with that sort of foundation. So we looked at antibiotics as one of the first kind of non-chronic disease studies we did, in part because my undergrad's in microbiology, so I got all excited about antibiotic stewardship, and I'm a family doc, so I thought this is a great way to go back to my days as a microbiologist. And what we found was that quite a lot of variability, and in fact, a small proportion of providers account for the majority of the actual sort of quote-unquote potentially unnecessary prescribing. So that's sort of 80-20 Pareto chart kind of rule. And I thought it was really interesting at the time. Look, and then everyone said, no, of course, we would have expected you to find that. So we did an audit and feedback study as part of a randomized trial, and we, again, showed, as Kevin had showed, that we could improve things a little bit. We randomized to 3 different groups. One got a tailored report, one just got general information, and the other got no report. And both the groups that got a tailored report and just a general, we're looking at your antibiotic prescribing and here's some ways you can improve, they both improved. So that Hawthorne effect really is real. Again, we just reinforced what was already known. So then, fast forward, our provincial administrative data warehouse, called MCHP, the Manitoba Centre for Health Policy, we sort of advocated, my group and others advocated to them to do a provincial report, which we did, and then that built up some momentum to actually try to do this reporting province-wide, which has now been sort of bolstered by Kevin's study. And so we're now using our administrative data, which has dispensing information, to be able to send out audit and feedback reports to everybody. And then the sort of future-focused work that I've now shifted towards is trying to figure out how we could zero in on that high prescriber population. So that interesting finding that most people actually are doing really well and are actually pretty judicious, but there's a small number of folks that really are not that judicious, has always kind of motivated me to think from my sort of quality improvement lens, like how could we address those prescribers? And so right now we're actually in the early stages. We've just started with our first 2 clinics of doing a targeted facilitation. So intentionally picking out clinics where there is at least one high prescriber and actually doing a facilitated sort of intervention. It's led by a pharmacist who then does a bit of an academic detailing kind of approach and provides some quality improvement tools, some of the tools and supports that come from Choosing Wisely. So there's a whole bunch of sort of things that Choosing Wisely has developed over the years to try to reduce unnecessary prescribing, particularly for antibiotics. And so we're trying to kind of encourage the providers to use those tools and doing it in a way that doesn't single out like you're doing a bad job, doctor, whatever, but actually presents to the whole clinic. And we don't actually say, Dr. X is a high prescriber, because sometimes there's actually quite rational reasons. Different styles of care, different types of practice. But when you actually drill down to the data, even for those who see like lots of urgent care type visits, there's still a skew. For people, there are just those of us out there who are prescribers, sometimes we don't know the things we don't know. And so we've done this approach before in some other sort of targeted interventions, focusing on sort of educational things where people don't always know the things that they don't know, which seems obvious, but is not the way we generally sort of try to do quality improvement work in primary care, because it's so heterogeneous and diverse. Often we end up doing quality improvement work in the places that are closest to the sort of academic health centers, as opposed to sort of trying to shine a light on the places or individuals or teams that need a little bit of extra support. And that's what we're sort of testing out the mechanics of. And so hopefully down the road, through the CANBuild study, we'll have provincial-wide audit and feedback, and then we'll try to co-develop a bit of a program, and hopefully it'll be shown to be effective, don't know until we finish the study, that we can actually target out some prescribers or some teams for a little additional intervention. We'll see what works, hopefully, to motivate them to change. So we're sort of working on the science side of this to figure out what works, accepting that we don't need to do any more studies on audit and feedback. We need to figure out how do you get the folks that don't respond, because there's always a group that are responders and then a group that they don't read the report, they're not motivated to read it or see it, or various reasons, they're too busy, time, yada yada. So that's the part that we're really working on to try to improve. How do we improve the improvement? So we're getting there, hopefully.
That's great, yeah. Touch on a really important part, that's that the doctors that are most in need of quality improvement are generally not the ones that volunteer and seek quality improvement in that topic. And a lot of the programs that exist are voluntary in nature. You have to sign up and be interested in receiving it, which leaves a lot of gaps.
Yeah.
All right, I'm gonna turn over to Noah for this question. So Dr. Ivers, what I wanted to do is read you an example of the feedback we receive. So I sort of pointed out we send these letters out to family doctors in Ontario, and we give them an opportunity to both opt out in the future, but also to give us feedback or comments about the intervention. So this is an actual quote from one of the physicians, and I wanted to get your response on it. So this feedback report doesn't change my prescribing, as I'm already using my best judgment when prescribing antibiotics. Every doctor has a different patient population size, practice, scope, and complexity. This data would be more useful given to nurse practitioners or pharmacists.
It's beautiful, huh? Yeah, so
It's got all the things.
So I think that, so first of all, I think we should recognize that if this doc took the time to write back, we got them. So that's great. The people, like Peter and Alex both said, geez, there's a bunch of people that are really hard to engage. And those are the areas where we have the most for improvement. And it may very well be true that this individual that's responding doesn't have much room for improvement. I suspect the data shows they do, because otherwise they wouldn't have bothered to write back. But there's two separate problems there. One is about how do we engage the unengaged. This thing you're asking about is what does all this mean? What is this response? I think when you go to give feedback to clinicians, you're going to hear 1, 2, or 3 of the 3 most common responses, and they're all in here, I think. One is the data are no good. Sometimes there's expletives mixed in there. Second is my patients are different. That was totally in there. Yeah. And the third, which is usually not stated explicitly, but I think was also in there, was I'm doing my best already. Go talk to somebody else. I actually don't know how to do better than I'm already doing. I'm at 100%. Get off my back. Or if you want me to do better, you better give me some support, some help, some whatever. They don't say that explicitly, but I think it's in there. And that ties back to what Alex is saying, right? It's wait, if you're going to go to the doc, sometimes it's not quite enough to say this is the gap between where you might hope to be and where the data says you are. Because you're going to get some sort of response in terms of this. Sometimes you've got to do some sort of outreach, facilitation, that sort of thing to help those docs along. But I will also say this. At a population level, these things make a difference. So if we get 1% of responders saying, this is unfair, why are you judging me like this, even though it's not judgmental, that's probably worth the balance for the nudging the whole population in terms of antibiotic use. And my guess is that even though this doc doesn't think it's relevant or useful for them, I bet their antibiotic prescribing changes in the next, I wish we could look. Like I bet you it impacted them.
Yeah.
Kevin, can I add one small point?
Yes, please.
So the part B of what Noah was saying for the 3 reasons is also, it's somebody else's problem. It's not me, it's the dentist or the nurse.
Or the patient.
Yeah, or it's my patient, like, so my patients are more complicated. They're demanding it. It's because my patients demand it. And as someone who's
These are natural human responses, right?
Right, I think these are probably most common among clinicians.
Turns out doctors are human.
Yeah, but I think when you present data to other folks, even if they're not clinicians or prescribers, you're going to find similar kind of pushback. Like, what I'm doing is different because. So that's number one. The other component about that sort of, it's somebody else's problem is that ownership and that sort of responsibility is very challenging when you're already sort of pushed to the limit. So part of the solution is actually not to work harder, but to work differently or work smarter. And so, we have a challenge in primary care in terms of capacity and ability to care for the whole population, given the workforce we have, and there's lots of challenges around that. And so to sort of finger wag, if I waving my doctor finger rarely works with patients, it doesn't work with colleagues either. We need to actually work smarter and not just say to people, you work harder, family doctor. That strategy doesn't work, and that's part of the secret sauce of audit and feedback and facilitation is to actually figure out how you can be more efficient, in your processes as opposed to just, trying to remember or working harder or learning more.
Yeah. And to bring it back to like Noah's first answer is like why this works. And there was a trial out of Australia that randomized doctors to giving them personalized feedback with their data and their name, or they just sent them a letter about antibiotic prescribing education. References to guidelines and resources, and there was very little change when it wasn't personalized and include data. They needed that motivation. It's not that they didn't know what to do and they don't know the guidelines. It was alluded to before, we talked about from the, AMI and national guidelines. Like the guidelines themselves are generally not what is lacking in terms of the behavior change in antibiotic prescribing, but they need this extra motivation often to put it top of mind and make it important.
Yeah.
And so that combination of things, I think, is how this is working. So.
I think it's fair to say that in general, everybody knows we ought not to prescribe Piptazo for the guy with a cold. Like, pretty clear. So that's not the knowledge they need. What they need is the knowledge of how to avoid it.
Yeah.
Not the Piptazo, but so if we can provide them the how-to, the how to make, actually, by the way, doing it this way saves you time and whatever, that's useful. But finger wagging saying, don't you know the guidelines, not so useful, because yes, they did know it. It's a how-to problem, not a pure knowledge problem. And I think if we come at them with a credible, trusted source that like they, if the college becomes that, it wouldn't be in Ontario, but like, if it feels legitimately helpful as opposed to scary, God forbid I get a letter from the college, that's a good start.
Yeah, that's great. And I think it's a good segue to the next question I want to direct towards Katie. So, Katie, I was wondering if you could speak to some of the engagement work you've done in Alberta with physicians and partners for the work that CPSA is doing.
For sure, yeah. So the MD Snapshot has evolved over time. So initially it was a paper mail out, but based on member feedback, it's now an online portal. So with this, we do look at benzodiazepines, Z drugs, opioids, as well as antibiotics. So we took the work with Dr. Schwartz, and also next year is the MD Snapshot's 10th year anniversary to really redefine the page. So we didn't want to just make it look nicer. We wanted to make sure that it was having physicians look at their antimicrobial stewardship and really be able to answer, am I doing the best that I can? So we entered some new flags. So things that we looked at, and we just released it this month, was prescribing antibiotics over 7 days. Again, we know that there are times when this is appropriate, but again, just for those physicians to remember what they prescribed and was that appropriate. Also looking at fluoroquinolone prescribing, and then looking at patients who would be flagged if they received antibiotics over a 3-day period from 2 different prescribers. So that would include nurse practitioners, dentists, pharmacists. So those were our new flags. The other part of the MD Snapshot that we revamped was looking at the peer comparators. So in Alberta, physicians, even though they might have 1 or 2 disciplines, on their RIF, which is their renewal form every year, they indicate what is their primary practice. So that would be the group that you would be compared to. Again, we're never going to get these groups perfect, and if you are in a specialty that has less than 30 members, we would put you with another similar group just to maintain prescriber privacy. But again, looking at your peer comparators, we recognize that you have your own practice and it might be different, but it's probably going to be quite similar to the people in your comparator group. We do recommend our members to provide us feedback. There is a button on the portal, so if you feel like you're paired in the wrong comparator group or you have some questions about the data that you've received, we always encourage the members to reach out to us. We do want this to be a collaborative approach as opposed to a top-down approach.
Thanks, yeah, that's great. Okay, for the next question, maybe I'll open it up to anyone that wants to comment, but maybe I'll start with Dr. Singer at the end. So what do you see as the future in Canada for delivery of antibiotic audit and feedback? Like, where do we go from here, and it's a bit like, how do we get there?
I mean, I think there's the magic wand future and there's the sort of more pragmatic, realistic one. And I think some jurisdictions are probably really on the cusp of getting this right, which is universal audit and feedback. So everybody gets a report so that you know, and it's consistent, and it's repeated, and it's an ongoing thing. And then, best case is we're able to fine tune those targeted interventions, and we can deploy them in a smart way. Sometimes virtually, sometimes just with small nudges. And then I think this sort of final kind of real process tool piece is having clinical decision support systems. So we still largely use electronic paper records in Canada, and so we don't actually have the technology embedded within the data systems that we use to capture like documentation to be able to, at the point of care, intervene. So, imagining sort of like the kind of process that exists in other countries where at the point of prescribing, maybe you get a hint or a nudge. And so, if I'm going to prescribe a macrobid for 2 weeks, the actual system would say, hey, are you sure you want to? The guidelines suggest a different approach, or, actually integration with sort of sensitivity reports or those kind of things, which for the most part come to us in paper. And so the process is to sort of combine the clinical decision with the important necessary background data like previous prescribing patterns or sensitivity patterns. Often doesn't exist and can't really be done in our current systems. So that's the ideal future would be all of this is integrated. And then, maybe we don't do universal audit and feedback, but we only provide audit and feedback on a sort of a rotating basis for different things. Because, again, everybody has different blind spots. We all have our own unknown unknowns. And so I think that's the direction I'd like to see. But it'll probably happen at different paces in different places.
Yeah.
Paces in different
I
places.
just came up with that right now. I'm going to keep that again.
pretty good.
Trademark.
Yeah. Comments from anyone else? Anyone else to add to that? The future, what does the future look like in this space? And
Yeah, I agree that speed has to be very, very important. So the intervention has to come as the pen is on the prescription or on the the digital entry, because I think what we learned in inpatient stewardship is 24 hours delay is way too slow. You can't give feedback that you better not give that broad spectrum after it's already been given, or a weekend, or late in the night, or you need a smart system that really acts quickly. I think the future of antibiotic prescription is regulation, and I think that's contentious, but we've learned from opioids that we can control prescription sort of centrally. I don't know how that would look, but I think that might be the future.
I wonder if a first stage towards that is, dictating that you have to have a diagnosis with the prescription. That would be, I would love that because it would make a data bonanza. Like we could give amazing analyses and feedback if we had that. Of course, people would game it because suddenly all your,
URTIs become pneumonias.
all your bronchitises are pneumonias and so on. But we can sort through that. So I think that's a first step. I think I do want to add that one issue with clinical decision support is that by the time you go to write up the prescription or type up or whatever, you've already made the decision. And perhaps you've already communicated it to somebody. And that's a bit too late to change it because you'll lose face. And I know that sounds silly, but it's legit. And so clinical decision support, that's one of the reasons it's not like computerized stuff is not like the panacea. No. We need to do other stuff as well. And audit and feedback is one of our really important and scalable and sustainable sort of tools in our toolkit. If I am a taxpayer, if I was representing the taxpayers and I heard that we have the capacity to give every doctor information about their prescribing, and I learned that we don't bother, even though it works.
And it would save money.
And that it would save money that I work hard for to give my taxes for, I'd be pretty annoyed. And that's the current state of play.
Yeah, maybe speak to that. So we're, showing that slide where we save $9 for every $1 we spend. This works, it's effective, it's scalable. Why don't we do it everywhere?
One issue is the dollars saved come from this budget.
Yeah.
And the dollars used to do the intervention come from this budget. And these silos don't connect in the back ends of our government offices. So I think that's one seemingly solvable problem. But it is a problem. If the folks that pay for the drugs would pay for the intervention, then that would solve that perhaps, but that's not what they do.
Yeah.
But there's one issue. And then the other issue is the things that we need to overcome as a culture professionally. This idea that collectively we ought to help ourselves to self-assess. Like humans are really crummy at self-assessment. We don't know what we don't know. And the data can help us with that, and we have a professional responsibility to use the data to help ourselves with that. We have to do everything we can to push our professional culture that way, I think.
Yeah. And there's a huge amount of inertia, sort of baked into that. You mentioned the sort of budgetary challenge, but there's just generalized inertia when there's a million fires to be put out within the health system. The cause du jour in Manitoba these days is emergency departments. It's the emergency department's overcrowded. Everything has to be focused around, overcrowding the emergency department. But that's really a symptom of a misfunctioning or malfunctioning, there's too many people coming in and not enough people leaving the emergency department. So that problem is a lot more complicated than just, oh gosh, there's people waiting too long. And so the inertia to try to solve the intake and the output problems take a lot more energy, and then where do you focus your energy when everybody's spread thin becomes exacerbates that inertia.
Yeah. Likewise in Ontario, if you come to anybody in the government right now with any kind of intervention that isn't about attaching people to primary care explicitly,
right.
You will get a cold shoulder. And I'm glad about that, don't get me wrong. So you have to reframe these interventions, and perhaps this could help. We're prescribing less, but it's a bit of a big step.
It's a bait and switch.
Yeah, we can probably talk about this all day, and there's a giant red clock counting down. So I wanted to maybe just take a pause and see if there's questions from the audience, if people want to ask the panel anything, or based on what we've been talking about. We'll give an opportunity. People want to come up to the mic. See someone either going to the washroom or no, come into the mic.
Hello, I have a question. Does any of you use CPD credits as an incentive to get clinicians to participate in those quality improvement initiatives?
Yeah, so any of these, the audit and feedback interventions, it's if you don't engage with it, it doesn't work. It's just like a drug doesn't work if you don't take it. And you got to do everything you can to get people to engage. And one of the things we routinely do is try to facilitate ways for them to earn credits by engaging in these activities.
By credits, you mean educational credits, right?
Yeah,
So you have to maintain your certification, either through provincial college or the national, your family medicine college, our family medicine college, to you have to maintain a certain level of educational credits. So we try to certify these programs so you get educational program credits. It's very hard to pay people specifically, actual dollars and cents, although there's some interesting literature on pay for performance among physicians, and it tends not to actually overall help outcomes because people just either game it or they do one thing and then they ignore something else because that's not the thing that has this incentive. So incentive pay for performance models tend actually not to deliver great outcomes, despite what people would want them to.
Yeah.
Elias, sorry about that. So I'm here as an MPH student, and so I'm here with the student hat on, but also I'm based in the United States. But based on my earlier research, we have, within the state of Utah, we have a council of the hospitals and all their suture programs. They kind of come together, share best practices, and they kind of filter that down the best that they can. is there any opportunity for that within the territories or even in like inter-territory? What does that look like?
It's tricky to go interprovincial. Like between each
Provincial
province,
side, yes.
the data is kind of siloed essentially. Within the province, I think there's sort of different, within each jurisdiction, there's different opportunities. So Alberta has a particular model. We're trying to develop something sort of collaborative, similarly collaborative in Manitoba. Different provinces have sort of different, slightly different models, and then also different relationships with the regulator. So the regulator in Ontario has a reputation for being a bit more punitive than in some other places.
I might have alluded to that.
And so then that, so the local, there's a truism, culture eats policy for breakfast. So you have to deal with the local culture. And it's similar in each province, but it is a little different. And so you gotta get those collaborations and those entities correct. And I think Alberta gives a lot of sort of credit to sort of having built something that has maintained its trustworthiness and engagement over the years and has been built on trust. And you can only do some of these large-scale things at the pace of trust.
Peter alluded before the idea of some competition. If you have competition that's like in a negative way, that doesn't help this kind of collaborative quality improvement approach. But some amount of competition that sort of enables comparison and then pointing out that the star performers in a region and asking them to share their secret sauce, this sort of approach is known as like positive deviant approach kind of to quality improvement. It's well practiced, effective, useful way to get people on board, I think.
Yeah, and I would make two comments to that. Our physicians have not always loved the MD snapshot. It has taken a lot of work to have them trust us that we don't use it punitively or to investigate their prescribing. And also, as a province, we are very open to collaborating with the other provinces. So we're actually having Saskatchewan come visit us because they want to see what we're doing, and we're kind of an open book to everyone because we do want to share across the country.
Cool.
Great.
I'll jump over when Saskatchewan agrees. And I'll tell the people in Manitoba, you got to go there too.
Thank you so much to Dr. Schwartz and the esteemed panelists for an amazing discussion. Let's give them a round of applause.